Hi, everyone. Thanks for joining. We'll begin in another minute or so. Good afternoon. This is Keisha Bohannon, and I work at CDC's One Health office in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of our office, welcome to the April Zoonoses and One Health Updates call. Next slide, please. This webinar is designed for veterinarians, physicians, epidemiologists, and other public and animal health professionals in federal, state, and local positions, but all are welcome. Today's webinar will be recorded. If you'd rather not be included, feel free to disconnect. Links to resources for each presentation are available on our website at www.cdc.gov/1-health/php/trainings-events/April-2026-ZOHU-call. Next slide, please. Today's presentations will address one or more of the following 5 objectives: identify an implication for human, animal, and environmental health, identify a One Health approach strategy for prevention of public health threats, identify a One Health approach strategy for detection of public health threats, identify a One Health approach strategy for responding to public health threats, list 2 ways to improve collaborative practice across the public health care team. Next slide, please. In compliance with continuing education requirements, all planners and presenters must disclose all financial relationships in any amount with ineligible companies over the previous 24 months, as well as any use of unlabeled products or products under investigational use. CDC, our planners and presenters wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Content will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial or in-kind support for this activity. Next slide, please. Instructions for receiving free continuing education are available at www.cdc.gov/1-health/php/ZOHU. To receive free CE for today's webcast, sign in or create an account at train.org by May 4th of this year. The registration code is ZOHU Webcast. A captioned video of today's webinar will be posted on our April call page within 30 days. Free CE for the web on-demand video of today's webinar will be available until May 5th, 2028. Next slide, please. Before we begin today's presentation, CDC's One Health Office Deputy Director, Colin Bassler, will share some news and updates.
Thanks, Keisha. Good afternoon, everyone, and thank you all for joining the April ZOHU call. Before we start the presentations, we like to share some monthly updates and resources. You can find links to these resources in today's ZOHU-call email newsletter. If you aren't subscribed to the newsletter, you can sign up using the link on our main ZOHU-call webpage so that moving forward you can get these updates. CDC is working closely with the U.S. Department of Agriculture, Department of Interior, and many other governmental and non-governmental partners to respond to an outbreak of New World screwworm that can impact livestock, companion animals, wildlife, and people in Central America and Mexico. You can find the latest updates on USDA and CDC's website and on the whole of government website at screwworm.gov. Next slide, please. In today's newsletter, we highlight several recent publications, including a publication detailing parental misidentification and potential mismanagement of dermatophytosis based on a nationwide survey of mothers in the United States. Additional highlights include a publication titled Freshwater Harmful Algal Bloom in Health, Awareness, Behavior, Perceptions, and Communication Preferences Among Adults in the United States. Another publication highlights tinea corporis and tinea curis incidence, risk factors, and treatments in a cohort of 6.8 million patients with Medicaid. And the final publication on this list highlights a multi-county outbreak of Salmonella agbeni linked to ice in a cooler at a county fair in Illinois. Next slide, please. The newsletter also highlights recent announcements and resources, including a CDC web-based training on fungal neglected tropical diseases, and a recent published invasive species accomplishments report from the United States Department of Interior. Next slide. Here are the April events and observances that may be of interest. The week of April 5th through April 11th is National Wildlife Week. The week of April 6th through the 12th is National Public Health Week. April 22nd is Earth Day, and World Veterinary Day is coming up on April 29th. Next slide, please. Finally, we've shared several new and ongoing outbreak investigation notices, including an E. coli outbreak linked to raw cheddar cheese, an extensively drug-resistant salmonella outbreak linked to moringa powder capsules, and you can visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past U.S. outbreaks of zoonotic diseases. And linked from today's newsletter, you can find details about additional ongoing U.S. outbreaks. Please continue to send presenter and topic suggestions for future presentations, as well as news from your organization to zohu-call@cdc.gov. We encourage you to share the ZOHU-call website link with your colleagues from public health, agriculture, wildlife, plant, environment, and other fields and sectors, so we can let them know about the live and recorded webinars and free continuing education that the ZOHU-calls offers. Next slide, and happy to turn it back over to you, Keisha.
Thank you, Colin. A Q&A session will follow the final presentation if time permits. You can submit questions at any time using the Q&A box. Please note this feature is available to the first 1,000 attendees. Please include the topic or presenter's name when you submit your questions. Next slide, please. Our first presentation, human cases of Carbapenemase producing Escherichia coli linked to spread between animals and the environment in a veterinary facility in Massachusetts, will be shared by Dr. Stephen Cole and Ian DiStefano. Please begin when you're ready.
All right, I'll take it from there. Thank you so much for the introduction, and thank you so much to the ZOHU-call hosts for asking us to come speak about this topic. This is super cool and exciting, so we hope that you find it the same. Next slide, please. So we'll talk a little bit today about CRE, or carbapenem-resistant Enterobacterales. I have a feeling that a number of the folks on the call are fairly familiar with these organisms, but on the off chance you're not, just a brief little bit of background here. What we're talking about here are a group of organisms, bacterial organisms falling into this class of bacteria, the Enterobacterales, and some of the prototypical types of genus level or species level bacteria that belong to this group include E. coli, Enterobacter, and Klebsiella, which commonly cause opportunistic, oftenly infections in human as well as veterinary patients. And we know that the carbapenem-resistant forms of these bugs are considered critically important pathogens to human health. and are commonly associated with hospital-associated infections, although there is some definite evidence out there of community acquisition or community onset infections as well. And we're starting to find that, unfortunately, we're starting to see these types of bacteria falling into this group as sort of emerging pathogens in companion animals as well. So far, kind of the focus has been primarily in cats and dogs when I say companion animals for the purposes of this talk, but that doesn't mean that they have not been identified in other animal species, sort of globally as well. And one of the subtypes of CRE that we've recognized has become particularly problematic in companion animal species tends to be this subtype we refer to as NDMs, which stands for New Delhi metallo-beta-lactamases. And again, it's just one subtype of CRE, if you will. Advance, please. And this is just a graphic that I took to give you an idea of, what do we know about carbapenem-resistant Enterobacterales in companion animal species? Well, the answer is not nothing, but we really have identified, and a lot of what's known about this has been out of anecdote and very recent publications. So just to highlight that this is truly an emerging problem and somewhat recent, and to give you an idea of what that looks like in terms of the primary literature. Next slide, please. So before we talk about sort of our One Health investigation, it would behoove us to talk a little bit about the background of how this came to be. And how this started was primarily in a veterinary facility in the state of Massachusetts, where this is a 24-hour referral practice for companion animals, so cats and dogs, again. And as part of sort of the normal hospital operations, we do at this facility have a sort of joint team of folks that work in infection control and antimicrobial stewardship. And as part of our normal operations, we tend to peruse our clinical culture data. And what we identified as initially a single isolate was a patient who had a hospital onset or hospital associated urinary tract infection caused by an E. coli, which was not only multi-drug resistant to a variety of different antimicrobials that we commonly use to treat E. coli infections, but in particular were resistant to carbapenems, which is not a normal occurrence for us to find. So this triggered us that that was abnormal, and we started to investigate. And largely what we found was, over the course of many months, somewhat of a smoldering outbreak of what turns out to be nearly identical or very similar phenotypic in terms of the bacterial culture and susceptibility testing E. coli infections, which ended up totaling a number of 19 patients, which all happened to be dogs. That we know of. And so this was based off of clinical culture. So the clinician who was treating the dog in this case, suspected that there was an infection, ordered a bacterial culture from some sort of tissue or bodily fluid isolate and grew this E. coli. And this resulted in a number of different infection syndromes in the hospital. There were a number of cases of bacterial pneumonia, but also urinary tract infections, surgical site infections, as well as one or two bloodstream infections. So not unlike the typical opportunistic or sort of hospital-associated infection syndromes that are described in people as well. And just to give you an idea of what this looked like as it was unfolding before our eyes in real time, this caused substantial morbidity and mortality, in my opinion, despite it being what seems like a relatively low number of patients, but not an insignificant number of patients by any means. But just under 60% of those patients survived to discharge, made full recovery. A little under a third died one way or another, and a few, unfortunately, were euthanized for various reasons. And to put it very simply, I would say that handling this situation was particularly taxing on the hospital staff and administration and sort of our infection control and stewardship team as well. Next slide, please. I say that in summary because, again, this is, this sort of initial veterinary investigation is not the focus of today's talk. We did sort of attempt to document the infection control and subsequent prevention efforts that were put into place to sort of mitigate this problem. And so just give you a few sort of highlights of what this looked like. We did perform surveillance in the hospital environment, looking for contamination in various areas of this E. coli, and found at its sort of its highest prevalence, upwards of 40% or so of sites that were cultured at its worst were contaminated with this particular E. coli. And then intermittently, we did actually screen hospitalized inpatients as well. So did point prevalence testing of hospitalized patients looking for colonization of this bacteria in the GI tract. And at that same sort of highest prevalence point in the environment in terms of overall environmental contamination, we also had our highest single point prevalence of inpatient colonization rates, which were upwards of 25%, which is quite substantial. All of the surveillance testing that we took as part of this investigation, both from the environmental samples as well as samples taken from clinical patients, were all sort of sent to the University of Pennsylvania Veterinary Diagnostic Laboratories, which Dr. Cole will talk about momentarily, which becomes relevant to sort of this One Health investigation we'll go into more detail on. I did include here just a snapshot of a publication that we wrote up highlighting what we did in the veterinary facility more specifically, in case you're interested in sort of the specifics of what the space looked like and sort of the timeline and how we were able to thankfully effectively control that. And keeping in mind that at the time that this was occurring, the point of our interventions was not to publish a research study. We were very much putting out fires, but we decided to write this up to describe to the best of our ability what we actually did, with hopes that it would be helpful for other veterinary facilities. And I have heard anecdotes that a few places have found it helpful. But in case you're curious, I left the DOI at the bottom of this slide as well. Next slide, please. And to just summarize it into one single figure of what exactly was done, sort of as, again, the background for this One Health epidemiologic effort. There were a huge number of sort of interventions that we used, including managing sort of the environment, so decontaminating the environment very broadly, because this organism unfortunately had contaminated a wide variety of different areas in the veterinary facility. We use, as I've mentioned before, a number of different types of microbiologic sampling, both in the environment and screening actual hospitalized inpatients as well. This took coordination for sure with hospital operations, where we used designated exam rooms and elimination areas, keeping in mind that CRE love to colonize the GI tract, which seems to be true in animals as well as people. And keeping in mind in a 24-hour veterinary facility, some of these pets need a place to eliminate, particularly dogs, and traditionally that means outside. So we had to come up with designated areas for them to do so. We did institute certain flags or notifications in our electronic medical system, and had a number of different workflow alterations as well, including standardized sort of CRE, standard operating procedures, institution of different levels of personal protective equipment, and substantial training that went along with that, and alterations in how we transport patients that are known to be have a CRE infection or be colonized by a CRE organism as well. And a lot of this came down to widespread and education as well in a number of different ways. But we also consulted a number of experts, both the folks at the University of Pennsylvania lab, which Stephen will talk to you about in a second, but also our local Department of Public Health in the state of Massachusetts. And with this coordinated effort, we did ultimately find success, where we found both the prevalence of this NDM E. coli in our patients as well as the environment declined to 0%. So overall, despite it being a long process, it was a success, but took some time to accomplish. Next slide.
All right, thanks, Ian. And so, as Dr. DeStefano mentioned, all those samples from that outbreak were sent to the CREATE program at the University of Pennsylvania. Our CREATE program is Carbapenem-resistant enterobacterales, animal testing and epidemiology. And we have a variety of resources that we've created specifically for use in veterinary facilities facing or preparing for CRE outbreaks. But one of the resources that we offer, and the one that we'll focus on today, is actually we provide diagnostic testing for both isolate characterization as well as environmental and patient screening of CRE. And we're able to do that at a relatively low cost to make sure that there's a resource out there for veterinarians to face these CRE outbreaks using microbiological methods. And this is part of our PenVet diagnostic labs in my larger clinical microbiology lab that I direct as well. And the CREATE Lab at the University of Pennsylvania is actually a academic partner with the Minnesota Department of Health's Pathogen Genomics Centers of Excellence, which is funded by the CDC. And we've actually partnered with them as part of investigating further these One Health links between animal and human isolates of CRE. Next slide, please. So within that, we've developed an investigation framework using at the Pathogen Genomics Centers of Excellence, the PGCOE, at the Minnesota Department of Health, partnering with our laboratory. And so this is that outline of that framework here. A lot of the work is done at our laboratory, where we then will characterize the bacteria as whether or not they're carbapenemase producing. And also gather any epidemiologic information from the veterinary clinic itself. And then whole genome sequencing is performed at the Minnesota Department of Health using their pipeline and then analyzed using their pipelines. And as part of this framework, we then upload those whole genome sequences to the pathogen detection pipeline at NCBI, which then makes these publicly available. We'll actually match these isolates to closely related isolates that have also been uploaded to that area or to that database. Next slide, please. And so what we'll be doing just next is focusing in on a little bit of that work that we're doing there at the genomic level that then sprung to more of this investigation. So next slide, please. So initially what we did was upload our bacterial isolates from the animal outbreak at the veterinary facility, both environmental surfaces and from canine feces that were screened. And they matched with 3 human isolates of CRE. They were all E. coli's, they were all NDM5 producers, and they were actually all from Massachusetts, all 3 people as well too. Next slide, please. So to take a step back, in the state of Massachusetts, all CRE isolates from people must be submitted to the Massachusetts Department of Public Health, where they also do whole genome sequencing, and they also upload those to that NCBI pathogen detection browser. The Massachusetts Department of Public Health epidemiologists then investigate potential exposures, implement control measures when indicated, and clusters of 2+ matching isolates all have investigation performed to investigate those epidemiologic links. So next slide, please. So when it was just those 3 human isolates that had been uploaded to the NCBI pipeline, there was known to be 3 people involved, all within the same county in Massachusetts, a 79-year-old female with a urinary tract infection, a 63-year-old male who actually was found to be colonized with this same strain of CRE when they were screened after exposure to a distinct strain of CRE at a inpatient hospital. However, they had this strain and not the strain of interest in that screening. And then the third person was a 23-year-old female with a urinary tract infection as well, too. And with the standard approach to the investigation, there was no epidemiological link being able to be found, in particular links across different human health facilities that these people were exposed to or received treatment at. And then they also did not have any sort of recent history of foreign travel or medical tourism. And so they were unable to sort of resolve what the link between these people were based on just the genomes alone and any of the standard epidemiologic information that was collected on these individuals. So with the next slide, please. But when we put those animal and veterinary facility isolates into that same database and then performed our own analyses using the Minnesota Department of Public Health pipeline, we were able to show that some of these isolates were highly related. In fact, we had a human and an environmental isolate that were identical to each other, zero SNPs apart, so zero single nucleotide polymorphisms apart. And actually, all isolates were within 10 to 9 SNPs of each other. So these were highly related isolates, all producing the same carbapenemase and all from the same region of the same state and even the same region of the state as well, too. Next slide, please. And so I think Ian's going to take over what our next steps were.
Perfect. Yeah. So if you could just advance once. Yeah, perfect. Thank you. So to follow along sort of the workflow here in terms of the investigation framework, next it sort of became clear that these isolates seem to be obviously highly genetically related, as Stephen just mentioned. And so next kind of came the working with the local health departments, again, the Massachusetts Department of Public Health, kind of reaching out to follow up with some of these affected humans. Again, at this point, it was sort of known that it looked like all of these isolates were highly genetically related, and yet couldn't really find an epidemiologic link between them until we kind of investigated some of the isolates from the veterinary facility and looked into that further. Next slide. Okay, so this is just a figure that kind of gives you a rough timeline of sort of what occurred here. And what was found ultimately, the big time bottom line, is that each of these humans who had an isolate of this E. coli detected at some point, whether it was causing colonization versus an infection. Also, when the Department of Public Health went back and interviewed these folks and asked them about animal exposures, found that each of them had at least one pet who had been hospitalized at the veterinary facility that had this outbreak, which each of those hospitalizations, veterinary hospitalizations, temporarily matched with sort of the outbreak that was happening in the hospital and predated sort of the human isolate that matched the animal-human pair. So looking at this graphic here, if you kind of match sort of human and pet pair A, there was a dog who was admitted to our hospital a number of times over the course of a few different months. And if we define month one as sort of the first hospitalization of the pet in the veterinary facility, by month two was actually when we sort of started performing environmental surveillance in the veterinary facility, realizing that we had a few clinical isolates at this point. Mind you, this animal itself was not sampled themselves in terms of had a clinical culture or was not tested for colonization of CRE in their GI tract. But subsequently, by month 5 of this sort of overall investigation, one of the human owners of this dog was one of the humans who had a positive urine culture, which occurred after the pet potentially had exposure to the veterinary facility during its sort of contamination and early investigation. And that theme kind of rings true for the other two pairs here, although the timeline's a little bit shorter. Now, mind you, roughly from month 1 or 2 of that, as represented in this figure, till about month 9 was kind of the overall span of the outbreak in the veterinary facility. So each of these pets, human and pet pair B, who happened to be a cat as the pet pair, and human animal pair C, were both hospitalized in sort of month 8, at which point we were still kind of getting the outbreak under control in the hospital. And so, again, the human B had a cat that was hospitalized just for 24 hours or so in the hospital about a month prior to their rectal swab testing positive for a very similar E. coli. And dog C, associated with human C, was hospitalized during that same month 8, and 2 months later, that human had their urine culture pop up positive for a very similar E. coli. And in addition, which is highlighted in a recent publication that kind of summarizes this whole investigation, we did a number of other isolates from environmental surfaces that were positive for, again, isolates of E. coli that were genetically extremely similar to one another, kind of all the way up until the study endpoint. Next slide. And so there are a couple of major highlights from this investigation. One is that while each of these human pet pairs, the pet themselves was not tested for CRE during their hospital stay because we used point prevalence surveillance. They just happened to not be sampled. The temporal relation between their exposure to the contaminated veterinary facility and subsequently their owner being found to have, an infection isolate or being colonized with this organism does suggest that perhaps the human's exposure was related to their pet, which was related to the environment or the facility where the pet had stayed previously, and kind of demonstrates the real need for kind of this real-time investigation of multi-species approach, given that, the detection of sort of the relatedness of all these samples was a fair bit after, the human infections had occurred and certainly had occurred after the outbreak mitigation in the veterinary facility had occurred, meaning that, our ability to detect this was only after the fact rather than in real time as part of a overall control effort, but definitely suggests that there's, a public health implication here for, infection prevention and control efforts, if you will, in veterinary facilities as it relates to companion animals and sort of closeness with their pet owners. And then the other thing that's sort of unique about this, which is a little odd, is the specific subtype of this Carbapenemase producing E. coli, which is this subtype ST162, which is just not one of the more commonly described problem carbapenemases that have been described in the literature already. So this seemed like, not related to one of the more well-known carbapenemases in this NDM subclass of CRE that has known to cause outbreaks in human healthcare facilities before. Next slide.
So just to sort of bring this all home, I wanted to highlight a paper that was just published in Emerging Infectious Diseases just this past month, where we look at all sort of the carbapenemase producing enterobacterales that are found in that NCBI database across the United States. And just to highlight it, I know there was a zohu-call about some of this data last year, but just wanted to point out that this is published now and that we've been able to identify, 11 One Health clusters where people, human isolates and animal isolates of CPE are incredibly closely related, speaking to the likelihood that this probably bidirectional spread of these organisms is occurring, and the predominance of this rare but concerning New-Delhi metallo-beta-lactamase, which lack a lot of therapeutic options and have been shown also recently to be expanding at a very high rate within the United States, and seeing the parallels occurring both in the human and animal populations, having concerns, and particularly rising of community-associated NDM infections and the rise in animals as well too, that it just speaks to the importance of these One Health investigations and strategies for controlling CPE, CPCRE in both animal and human populations as well too. And so next slide, please. And so I just always like to bring it home with why it matters. Of course, we're concerned about animals potentially being an important reservoir within our community. Pet care is also an important and growing industry in the United States. People believe that pets are part of their families, right? And pets help us live happier and healthier lives. They help us be more physically active. They help us maintain social connections and maintain routine and provide companionship as we need them to. So this isn't to scare people away from pets, but it's to highlight us to the need for infrastructure to support veterinarians to prevent these organisms from growing so that we can then prevent them from spreading within our homes. These are Adler and Princess Margaret, my babies, and I know that I live closely and intimately with them as well too, and as many Americans do. And so we need to keep an eye on this emerging threat to pets and the impact that that could have on the people who love them as well. And so with that, thank you very much for your attention today.
Thank you so much, Dr. Cohen DeStefano. Really grateful you were able to share this with us. Okay, for our next presentation, it'll be Francisella tularensis, subspecies holarctica, in stranded beluga whales in Cook Inlet, Alaska. This will be shared by Miss Natalie Rouse. Please begin when you're ready.
Okay, thank you so much for having me today. Really appreciate the invitation to the call and really interesting last talk. So I'm happy I got to hear that. My name is Natalie Rouse. I am a necropsybiologist for Alaska Veterinary Pathology Services and the University of Alaska Anchorage. I do dead stranded marine mammal response here in South Central Alaska and throughout the state. Next slide, please. I want to first acknowledge all of the collaborators and contributors to this work. The photo on this slide just shows one of the teams that responded to one of these strandings on the ground. That's just a few of the people that start the responses that gets the samples for these projects. And then there are tens of people on the back end, our diagnostic labs, our federal partners, all of that contribute to this work. So I just want to acknowledge that this is a huge group of people that helped make this finding. Next slide, please. A bit of background. Francisella tularensis is also called tularemia or rabbit fever. It's a gram-negative bacteria and a zoonotic pathogen that affects humans, mammals, and birds. The infectious dose is extremely small, so because of that, it's a potential agent of bioterrorism and probably why most of you on this call have heard of it. There are two subspecies that are pathogenic. There's type A, subspecies tularensis, and type B, subspecies holarctica, which is what we'll be focusing on for the most of the rest of this talk. Humans can contract tularemia from inhalation of contaminated water, a bite from an infected insect, or from handling infected wildlife. So pretty much huge variety of ways that you might come into contact. Symptoms are flu-like and include swollen lymph nodes, conjunctivitis, ulcerative skin lesions, pneumonia, and potentially septicemia. And they're dependent on the route of exposure. So you'd have quite a different presentation if you were exposed by inhaling contaminated water, for example, as opposed to being exposed through your skin. This bacteria is ubiquitous in the northern hemisphere, and it's frequently associated with freshwater. However, previously it was not typically associated with the marine environment. So this finding was a big shock to us. In fall of 2023, the very first marine mammal case was reported in Washington State after a biologist became sick after doing a harbor seal necropsy, and they confirmed that it was tularemia and that the harbor seal also had an infection. There were two additional cases in the same area in South Puget Sound in June 2024 and in February 2025. Next slide, please. And meanwhile, up in Alaska, 2,000-ish miles north, we were doing our work responding to Cook Inlet beluga whales. Cook Inlet beluga whales are a critically endangered population of beluga whales that reside year-round in the waters adjacent to our largest city, Anchorage, Alaska. Their population is only about 300 individuals at this point. down from over 1,000 in the 90s. So they're watched pretty closely, and we respond to every single dead stranded animal that is reported. And we saw a significant uptick in dead stranded animals in the fall of 2023, where 7 whales were found dead in a very short period of time around the fall equinox, in about 60 days around the fall equinox. That's pretty unusual because we only get about 1 to 5 dead stranded animals a year. And so having that over the course of the whole year. And so having that in just 2 months was alarming to us. And it really reminded us of another similar uptick that we saw in 2017, where we had 10 whales right around the same time period, and we never did figure out what the cause of that event was. The gross pathology for both of these events included pulmonary edema, mottled lungs, enlarged marginal lymph nodes, and ecchymosis in the blubber. Histopathology confirmed we had pleuritis, multifocal bronchopneumonia, multifocal random hepatitis, lymphadenitis of the marginal pulmonary lymph node, and ecchymosis in the blubber. Routine culture and PCR for all known pathogens that we have seen in this population and other populations of marine mammals did not reveal the etiological agent. So we were a bit at a loss. Unlike 2017, we had the option this time of sending some samples to our lab next door, at UAA, the Bort's lab, and they did some agnostic sequencing for us to try to figure this out. Next slide, please. They used Oxford Nanopore Rapid PCR barcoding on a MinION device and were able to find Francisella in 2 of the animals, liver and lung. And honestly, we were pretty shocked by this. And we kind of didn't believe it at first because it had never been found in a marine mammal, and we didn't know about these Washington cases at this time. So, and it found out about it, right a little bit after. So, they were we wanted to confirm this result, and so we sent several samples to Colorado State University to test and confirm by PCR, and those came up positive for those 2 samples that the Bort's lab sequenced, as well as several of our other animals from 2023. They forwarded those products and samples to the CDC for MLST and on 6 genes. And that also confirmed that we had Holarctica, Francisella tularensis holarctica. We also did IHC at the Kansas State Veterinary Diagnostic Lab, and it was read here by our pathologist, Dr. Bjork Huntington at Alaska Veterinary Pathology Services. Phylogenetics was done. Amplicon sequence reads were referenced to the tularensis subspecies holarctica live vaccine strain and aligned with other available sequences of Francisella tularensis and Francisella to construct the phylogenetic tree and place the isolate strain in a clade that was identical to the 2023 Washington State harbor seal. So that was pretty interesting. And so these are the first known cases in cetacean worldwide. Next slide, please. This slide just shows the histopathology confirming the gross findings with inflammation and coxal bacilli in our lung and liver organs. This pattern represents the pneumonic form of the disease, so we're fairly confident that these animals were exposed by contaminated water, which is a pretty logical conclusion given that they're whales. And we published a research letter in Emerging Infectious Diseases on the 2 cases that were sequenced in June of 2025. And the DOI is there if you guys want to check it out. Next slide, please. Since that time, we've been working this up a little bit more. We've done retrospective PCR and IHC analysis on those cases, the rest of the cases from 2023, and all of our cases on our archive samples back to 2012 for all of our cook inlet belugas. We confirmed that the 2017 event was in fact Francisella as well. We got 7 more cases, 1 suspect case in 2016, and we confirmed an additional case in early 2024, bringing our total to 5 cases from 2023 and 2024. We also verified that we did not have Francisella in any of the other years back to 2012. And of course, we've been continuing our surveillance on hook and lip belugas and other cetacean and actually pinnipeds as well that we respond to in our area. Additionally, part of my PhD project is going to be looking at potential environmental drivers of these Francisella events in our hook and lip beluga whales. And you can see on the right side, that's just what the IHC looks like. The pathologist was very excited about that because it was apparently a lot pretty striking compared to some of the IHC that she gets to read. So thought I'd put that up for you. Pathologist, next slide. Yeah, so pretty straightforward. But we just need to be looking out for this in our marine mammals when assessing any health in the Arctic going forward and everywhere else really as well. This can happen. So a new thing that we need to keep track of and protect ourselves from. Humans working in the marine environment need to be aware of the possibility of exposure and take appropriate precautions. And healthcare providers, of course, we have tons of people recreating in this area where these belugas are swimming. So just want folks to be aware that it's out there and a possible thing going on. So next slide, please. That's all I have. If you have any questions, feel free to email me. I might bump them to some of my collaborators because this was certainly a group effort and not all of it was my area of expertise. So I hope I presented it well. Thank you.
Thank you, Natalie, and thanks to all of our presenters today. You definitely got a lot of surprise faces on your slides, Natalie. So thanks for sharing. We have time for a few questions. As a reminder, if you have a question, please use the Q&A feature to send it in and include the presenter's name or topic if you can. Let me go to the Q&A. I'm going to start with our first presentation to give time for some other questions to come in for the second one. Do you see other facilities such as grooming and daycare at high risk for spread? And what type of education and mitigation strategies are in place for these sites? Would you, oh yeah. Feel free
I guess
to,
I could start on
So-
that one if
Yeah.
if you want, Stephen. So I guess that's an excellent question. I think I would caution, I'm not sure I would say high risk for spread, only from the standpoint of there's still relatively little that we know about overall risk. And frankly, that's been one of the largest challenges in communication about CRE in companion animals is communicating risk to, hospital workers, involved in the outbreak or in the referral community, and to pet owners and other sort of other facilities in the area that may not be, for healthcare, but otherwise involved in pet care in some way. I would say, however, that, yeah, I mean, any animal facility, I think, is potentially vulnerable to potentially unknowingly, contributing to dissemination of some of these organisms. This is not by any means, by any stretch of the imagination, the first sort of multi-drug resistant class of bacteria that has emerged in companion animals over the years. Although I think we're a little bit better at looking out for this sort of thing at this point. We haven't necessarily, or at least I've not had direct communication in terms of education and mitigation strategies with those sorts of sites, like non-veterinary healthcare associated animal sites. But we have had, a number of conversations with pet owners who have been, interested in, my pet is not sick from CRE, but we know that it's, colonized their GI tract. what does that mean for daycare? What does that mean for grooming? We do highly discourage the use of those facilities for those pets. But yeah, you've identified a good point, which is that it's not just about the veterinary facility itself, it's about pets as a potential reservoir. And because this assimilates into their, quote unquote, normal GI flora for at least some hunk of time, it's possible for, it's very possible for sort of asymptomatic carriage and having implications in those sorts of facilities. So we have always heavily, very strongly discouraged the use of grooming and daycare for pets that we know are CRE positive, which can be very tricky in terms of pet ownership.
Thanks. Okay. I'm gonna give you guys another question for our first presentation. Can you share any perspective on how the owners of the positive pets reacted to learning about the CRE infection in their pets, and what changes they may have implemented in managing their pets in their household going forward?
I can speak to some of the pet owners we've seen in our facility at Penn, and I think maybe we can compare it with Ian too, if it is. In general, the owners, they're primarily worried about their pet's health, right? Like, how does it impact their health of their pet? They usually, understand, most of the time have a fairly understanding reaction to the fact that, hospital-acquired infections do occur, and there's always a risk, right, that's associated with it. And then many of them are willing to put into place, the precautions at home that are reasonable precautions, right? So making sure that they're careful around feces, washing their hands, making sure that they're not interacting with high-risk individuals potentially who could go on to become colonized or have infections with that CRE. Two, I think for some of the ones that go on longer and longer, they can get frustrated. Certainly, I understand why it would be a very frustrating situation. A lot of the time, they're very concerned that they won't receive adequate pet care because they're concerned about if we're going to treat their pet any differently because they are Shiri colonized, and not give them the care that they deserve. But certainly, that's never the goal, and it's not what we're doing at PenVet, and something that we like to communicate really clearly to them. Ian, I'm not sure if it's been fairly similar for you guys. I mean, the reaction can be all over the place, but in general, that's it.
Yeah. Yeah, I would agree with all of that for sure. That's one of the things that we stress first and foremost is that, one, this isn't going to affect the quality of care that your pet's going to receive. And a lot of the coaching and education of pet owners that we've focused on has really just been applying known sort of pillars of infection prevention at home as much as possible. So, we don't necessarily, we don't, I would say, actually, ask owners private questions about folks that might be at home, whether it's them or a different family member, about, immunocompromised status or chronic health conditions, but instead, kind of reinforce the critical importance of sort of really good hand hygiene. Dealing with the pet's excrement is a big deal depending on where they live. Like where Stephen works, it's in the heart of Philadelphia. It's in the middle of an urban environment. Where I work, we have a variety of different clients that range anywhere from super rural to urban environment. And where their pets eliminate is something that we've had to really think about and how to handle the pet waste. And so really driving home, good hand hygiene, being particularly careful with their excrement. And yes, we've said, in a perfect world, it would be ideal to semi-isolate your pet if that's feasible. And one of the other things that we really drive home is don't do anything that's going to significantly, affect your way of life at home for a theoretic risk, right? So if it's really just depending on where they live, the layout, their lifestyle, it's not possible to keep that one pet who we know is colonized as CRE completely isolated and separate from another pet, then that's just not possible, right? And so that's something that we accept. And so how that looks for each pet owner is a little bit different, but I would say I have never had a negative client interaction when I call and have counseled them. And, historically, what I did was sort of at least internally a standardized communication plan. We now at Tufts have a full-time veterinary infection preventionist who's wonderful, and she kind of champions all of that. And we now have a very standardized way that we communicate at-home education for these pets. Granted, it's not often, thankfully, that we need to do it at this point, but we have that workflow put together. And I would say, I've been very pleasantly I've been happy with the overall owner's response, and that most people are at least understanding, if not maybe a little frustrated or worried, but never have sort of had an overly negative reaction to breaking the news.
Thank you. I'm gonna move over to our second presentation. Got a few questions there and a couple that are similar, so I'll start with those. Natalie, any thoughts on what this might say about exposure and transmission route of Francisella?
Yeah, so with um, with our cooking belugas, based on the presentation of where they were infected, we think they're getting infected via the water. And um, so, how did it get in the water? We have it in the terrestrial environment, so absolutely, that seems like a logical conclusion, but the question really is why? Why hasn't it happened before now, and why during these two time periods? So that is something I'm looking to dive deeper into for one of the chapters of my PhD. Belugas do, I see kind of one of the other questions is that, they are belugas swimming into fresh water, and they absolutely can. They are sometimes known in other populations of beluga to go up to 500 miles inland up the river, and they can happily be in fresh water for quite some time. So yeah, that's certainly a way that they could be exposed.
Thank you. Um, was there any follow-up with people who handled the belugas and any concern for human illness that may have been tularemia? And what PPE is used for marine mammal collection and necropsy now?
Yeah, everybody, we have just a pretty small, tight stranding network up here. And fortunately, none of the human folks that responded had any issues. So we were really lucky in that sense. And in 2023, we were already wearing masks just simply because of COVID. So that I was real thankful that had already happened. But back in 2017. I'll admit we didn't always wear masks. We just didn't think we needed to when we were outside. And so we certainly do now. Everybody's fully protected, and we also are, taking precautions for influenza A as well. So everybody's in full PPE at this point for all of our necropsies.
Great, thank you. Gonna skip back over to Dr. Cole and DeStefano. And apologies if you have already answered this question. How severely were the humans affected who had the CRE infections?
The one individual was just colonized and never had any negative outcomes secondary to that, and then the two others had, I believe, they were recurrent UTIs that they had suffered from, and however, I believe this isolate was susceptible to nitrofurantoin, so it was able to be treated with a urinary specific tract drug, but I would have to confirm that.
Yeah, I was going to say, so neither Steve and I were the folks that interviewed these
Yes.
folks directly. It was our colleagues at the Massachusetts Department of Public Health. However, that's also my understanding is that the two people that were affected, had signs of a clinical infection, that they were treated and resolved.
Awesome. Thank you. Back to Natalie. Did the UAA group reach out to the Alaska Wildlife Conservation Center to see about overlapping cases in their wildlife residents during the same time frame as the belugas?
So I have not spoke with them specifically, but since it's a reportable disease, we've spoken with the state vet, which they would have needed to report if they had any cases, and as well as their veterinarian, and reached out to them, and they didn't have any cases. So I don't think that they had any overlapping cases at that time.
Thank you. Um, are there are there any known similar cases in East Coast wild belugas? And what about aquarium belugas?
They're not. These are the first cases in any whale at all worldwide that we're aware of.
Yes, this is why it was so shocking. Okay, thank you for clarifying. All right, well, thank you guys so much for your participation, sending in questions, and thank you again to our presenters. We are almost out of time. Um, if you have any other questions for today's presenters, we've included their email on the slide before this, but also on our April call webpage. A video of today's webinar will be posted within 30 days. And please join us for the next webinar. Okay, here's the slide with their emails. Please join us for the next webinar on May 6th. And this will end today's webinar. Hope to see you next month. Bye.